I'd like to thank Barry for once again inviting me to this fantastic meeting we have once a year. And Barry gave me a very difficult task of talking about carotid surgery for stroke, who, what, when, and why. My talk has been sponsored by Bayer. And I'd like to just mention that, stroke is responsible for 9% of global mortality in males and 11% in females. The age-adjusted incidence of stroke ranges from 94 per 100,000 persons in high-income countries, rising 117 per 100,000 in low to middle-income countries. And with the rising diabetes epidemic in the low-income countries, I think we're going to see much more. This review in the Lancet showed that there's been a 42% decrease in stroke incidence in high-income countries, and this probably is related to best medical therapy, and a greater than 100% increase in stroke incidence in middle-income countries. The definition of stroke and TIA has always been a problem, but essentially, where you have TIA, transient ischemic attack, lasting less than 24 hours with no neurological fallout. And in essence, also TIA has been shown with MRI that many patients with TIA also have evidence of acute infarction. And this has led to proposals that the classic definitions will have to be revised. Now, the etiology obviously is at least 25% are related to carotid artery disease. The rest are shared between cardiac embolism, small vessel intracranial disease, and even presently about 25% we don't find the cause. Now, who should be offered intervention? Clearly, symptomatic patients between 50 to 99% carotid stenosis presenting with hemispheric symptoms of stroke, transient ischemic attack, or amaurosis fugax. I'm going to, at this point, categorically say, to improve cognitive function, there's no evidence that carotid revascularization improves cognitive function. And to date, there is no compelling evidence that carotid interventions either improve or prevent cognitive impairment. And this also came out in the European guidelines. Now, the criteria for diagnosing the stenosis in most vascular units would be with carotid ultrasound. And there are three different methods of identifying carotid stenosis. And I'm not going to go into it, but just to make sure that if you have a lab, that it should be properly validated with invasive monitoring. These are the recommendations that have come out from the European Society of Vascular Surgery, where basically carotid endarterectomy would be recommended. They've given a 1A recommendation in patients with preceding 6 months of symptoms who have had a 70 to 99% carotid stenosis, provided the documented procedural death or stroke rate is less than 6%. Of significance is the recommendation 39, where carotid endarterectomy or stenting are not recommended in symptomatic patients with a chronic internal carotid near-occlusion unless associated with recurrent ipsilateral symptoms, despite optimal medical therapy. And it should be, again, following a multidisciplinary team review. So what is available to a patient with a stroke? Clearly, systemic thrombolysis, including catheter-directed thrombolysis. This usually is the so-called 6-hour time period. You have carotid endarterectomy. There's transfemoral carotid stenting, which I'm going to refer to as CAS, and then transcarotid revascularization with flow reversal, which is the new kid on the block, TCAR. Now, clearly, the 12 trials with thrombectomy versus controls have clearly shown that it favors intervention. Death, as well as the Rankin scoring improved significantly. And the numbers needed to treat to prevent one functionally dependent outcome was 5.4. So the overall benefit for early thrombectomy, whether it's intravenous or catheter directed, is clearly evident in presently. Now, the important question is intracranial hemorrhage post-carotid endarterectomy and stenting. Early CEA were only 2 to 6% are eligible, but there's strict criteria where you have rapid neurological recovery, where your modified Rankin scoring is 0 to 2, area of infarction is less than 1/3 of the MCA territory, where recanalization of a previously occluded MCA has been achieved. And if you have an internal carotid artery stenosis of 50 to 99% stenosis, provided you have no parenchymal hemorrhage or brain edema, but very important, if you're going to obviously offer these patients intervention, then post-op BP monitoring is mandatory to prevent the hyperperfusion syndrome. The other question that has come about, intracranial endovascular therapy, there's a twofold improvement in functional outcome. There is no current data to guide the clinician as to whether synchronous or staged intervention for ICA stenosis. In the ESCAPE trial, they were advised not to routinely perform CAS at the time of mechanical thrombectomy. But I think clearly each unit needs to establish their treatment protocols with a multidisciplinary team. The carotid endarterectomy, which has been one of the most important, if I may say, operation that has undergone scrutiny is the carotid endarterectomy. And certainly using a patch today, we have improved our outcomes significantly. Now, carotid endarterectomy is established in symptomatic carotid stenosis of 50 to 99% versus medical therapy. There is no question about this. Multiple randomized trials early in the 90s and later have shown that there is evidence for benefit. High quality evidence definitely exists for 70 to 99%. And there's moderate quality evidence for 50 to 69% stenosis. Less than 50%, there was no benefit. And this was assessed by Rothwell and Bonatti, both showing clearly that the high quality evidence exists for 70 to 99% stenosis. Transfemoral stenting, this is also another option for a patient with stroke where there's carotid artery stenosis, and certainly with the filter has improved outcomes. But problem early period post-transient ischemic attack or stroke is controversial for carotid stenting because there's been an 8% 30-day stroke rate if it's done under 14 days. Certainly CAS has been used in patients above 70 years old. There's increased risk of stroke. It's been used where there's been high risk for carotid endarterectomy, either because of patient's physiology or because of the anatomical site. But there's no doubt that short-term, 120 days, there is a higher stroke risk and death risk with carotid artery stenting as compared to carotid endarterectomy. Long-term, there's no difference in annual rate of ipsilateral stroke. But what is also interesting is 3 times more patients in the stenting group than in the endarterectomy group had a new ischemic lesions on MRI scanning, post-treatment scans. A new kid on the block is transcarotid revascularization. And this is where you make a small cut in the neck above the clavicle, cannulate the common carotid artery, and then start a flow reversal with a cannula in the femoral vein. And then you have a filter in the center, which will then basically get rid of your clot. But the flow reversal prevents you from putting further wires or putting in a filter system distal to the lesion. Now, TICA, early data suggests it may have a role in treatment of patients with symptomatic carotid occlusive disease. It has a similar rate of diffusion-weighted infarcts on post-procedure MRI compared to CEA, while transfemoral CAS is still associated with the 2 to 3-fold high rate of diffusion-weighted infarcts. And 50% of these diffusion-weighted infarcts in stroke occur following transfemoral carotid artery stenting are usually in the contralateral area, suggesting arch pathology. With transfemoral carotid stenting, you have to cross the arch where there's a lot of disease, and this possibly is the source for this infarction. Now, two recent trials, the Roadster 1 and 2, have been completed, and the incidence of 30-day stroke in symptomatic patients per protocol was 0.6%. There were no deaths in the per protocol symptomatic patients in Roadster 2 for a combined 30-day stroke and death of 0.6%. A more recent study has also shown that TICA in hospital stroke and death is much less than transfemoral stenting. And there another review by Malas and Co. showed no difference in in-hospital stroke and death between symptomatic patients undergoing TICA versus CEA. And also it was associated with less cranial nerve injury and shorter hospital stay. It seems to be TICA is promising and safe with favorable technical success and low periprocedural stroke rate and cranial nerve injury. There is unfortunately inadequate data to make recommendations of low surgical risk patients who are symptomatic, because most of the studies were in high anatomical or medical risk patients. And in fact, the Vascular Surgery of America, basically the guidelines, which are just about to be published, also confirm these recommendations. Now, when do you perform it? There's no doubt CAS is much better if performed early on, and less than 14-day intervention is where we should be going, especially with open surgery. And again, the recommendations when revascularization is considered appropriate is that it should be preferably within under 14 days from symptom onset. It is necessary to delay in CAS in those patients suffering severe disabling strokes, modified Rankin scoring more than 3, and with an area of infarction exceeding 1/3 the territory of MCA, or with altered consciousness, should not undergo carotid endarterectomy. However, in selected patients, one may still perform early emergency CEA. Now, the question was also posed to me, why? Certainly remember one thing, it's a prophylactic operation, but the long-term outcomes in multiple trials have shown very good results. This is both with open surgery and CAS, showing long-term outcome between 2 and 7 years. Although favors endarterectomy, CAS has also shown good long-term outcomes. And again, the procedural stroke rate with CAS and CEA are basically about the same. So in conclusion, CEA and CAS are durable. TICA needs further evaluation. Multimodality treatment is available for stroke patients. Guidelines are coming out and they are helping in making decisions, but I think multidisciplinary teams need to be established in treating patients with stroke. Thank you for your attention.
Thank you very much. That was an absolute superb talk. Maybe a 5-second question. Prophylactic, does that include asymptomatic? I mean, because we only spoke about symptomatic patients having carotid. What do you do in the asymptomatic patient that has got a stenosis of 60 to 70%?
Again, I think if you look at the long-term results, even though they are showing good outcomes, the ACST2 results, I still think you need to have a very low perioperative stroke risk, less than 2%, to give benefit to those patients. So asymptomatic patients, I would still offer best medical therapy.